Okay, I think we'll begin. I make it just after 1:45 p.m. Thank you for joining us, everyone, for today's event, Better Cardiovascular Care Through Data, which is part of Clinical Audit Awareness Week 2025. Today in Clinical Audit Awareness Week, we're focusing on the very important role that clinical audit plays in addressing healthcare inequalities. This event, which will end at 2:30 p.m, is about the role of CVDPREVENT audit in cardiovascular disease prevention and care, but above that, its role in helping healthcare professionals to make informed, equity-driven improvements in CVD care. And so I'm delighted to welcome today's speaker, Dr. Peter Green, GP and Clinical Lead for CVDPREVENT, who will give a short presentation after I've finished waffling on. And I'm equally delighted to say that Peter will be joined by two other panel members for a Q&A session after his presentation. And they are Liz Corteville, who is the Quality Improvement Lead NHS Benchmarking Network at CVDPREVENT, and Dr. Veena of Raleigh, Senior Fellow in Policy at the King's Fund. So as I've hinted, there will be a Q&A for the panel from 2 p.m. onwards, and this will be managed using the Q&A function, so not the chat. The chat is switched on, so feel free to use it, but we'd ideally like the chat to be used to a minimum so that we can keep an eye on the Q&A. So when we get to the Q&A part, after Peter's presentation, I will read out the questions because mics are muted, but get your thinking caps on now for anything you want to ask. And as Peter finishes his presentation, please put your questions in to the Q&A. Before I let you go, I'll finish my boring bit, which is the few brief housekeeping notes I've been asked to mention, which is that this event will be recorded and slides and recording will be available online on HQIP's website shortly afterwards. As I said, mics are auto muted and they'll be kept muted throughout. Cameras are on, but feel free to switch your camera off if you prefer. But we just like to allow that so that we can all form a community. The chat is available if needed for tech issues and so on, and for sharing links, but just to bear in mind that we won't be monitoring that for questions and answers for the Q&A section. Finally, I just want to mention, please feel free to share this event and everything going on for Clinical Audit Awareness Week on social media. Use the hashtag CAAW25 and do tag HQIP and we will reshare anything. So that's the boring bit from me. Without further ado, I'll hand over to today's speaker, Dr. Peter Green, CVDPREVENT.
So thank you very much for that. I'll just briefly run. So CVDPREVENT is a national audit of GP data relating to cardiovascular risk factors and cardiovascular care in England. So it's been running since March 2020. Each quarter we look at 63 million patients and we extract data from the relevant groupings, which is about 15 million. We take data every 3 months and there's about a 6-month lag between the data being extracted and us being able to publish the data around a number of the sort of indicators that we're looking at. And all of this information is in the public domain, which is very important, I think. And all of the data that we're getting on the audit can also be found in free-to-use reports in primary care. So rather than just an audit telling GPs what you got wrong 6 months ago, they have the tools that they can use in their own practices to find those individual patients today and to do something about it. So it's both about where you should be looking and then parallel tools to help people identify those individuals from it. So next slide. So when we set this up, we started looking at what we call cohort 1, so the 6 high-risk conditions, the hypertension, AF, cholesterol, kidney disease, diabetes, and non-diabetic hypoglycemia. And if you think about it, these are patients who are essentially probably feeling well, but have a risk factor that may need some monitoring and management and optimizing their care. We then looked at what we call cohort 2, which are the group of patients who've had an event of some sort, stroke, heart disease, heart failure, aneurysms. And then we also look at cohort 3, which are people who we may have missed the diagnosis of. So if you think about chronic kidney disease or diabetes, the definition of you having those conditions is just based upon blood results. And so sometimes people can have blood results that suggest they have that condition, but it's not been coded into their record. So we identify that cohort so that people could work through it. Equally, we break all this down by age, sex, ethnicity, deprivation, learning disabilities, and serious mental illness. And that allows us to do some further breakdowns of it. We've not got quite as far as we might like on some of the breakdowns because we're still looking at those mainly in silos. So when we look at ethnicity and deprivation, we don't know, for instance, some of the variations in ethnicity outcome, how much that correlates with deprivation or otherwise. And that's work we'd like to do moving forward. Next slide. So again, and it fitted with what the plan was at the time, which was save this 150,000 additional lives. And really what we're trying to say, are we monitoring so have we measured somebody's blood pressure? If we've measured somebody's blood pressure and it's in the range where they might have hypertension, have we recorded the diagnosis? Haven't recorded the diagnosis, have we treated them appropriately? And in some cases, are we over-treating them? So we have one of the filters that looks at people who are elderly and their blood pressure is potentially low, whereby it might increase their risk of a fall and they might be over-treated. And we're trying to look at that for all the different groups that we're looking at, so that we mentioned before. And then, as I said, there are the tools that run parallel to this, that run in the GP systems for them to be able to try and identify these individuals. Now, those tools are slightly different because they will filter out people who may be on a palliative care register, so it would be inappropriate for them to receive that intervention. And it will equally present that information back to practices with the highest risk patients first. So if you've got 100 patients, start at the top, start at the people with the most risk and work downwards. We're very aware people are busy, so we want to be able to help them focus their time on the things that will make the most difference to patients. So next slide. So again, we've got a number of indicators, and anyone can go onto the CVD Prevent. There are links through this onto the CVD Prevent website, and there are a number of indicators across a whole range of the conditions. But essentially, is have we detected it? Have we managed it? Are we over-treating? And when we're looking here, this is a slide on hypertension, and what we're seeing is the proportion of people treated to the age specific threshold. So as most people know, the people with over 80, the threshold is 140 over 90. Below 80, sorry, it's 150 over 90. Below 80, it's 140 over 90. So there's a slight difference in the age specific cutoff for that. And one of the things that we see with here is that there are fewer people being treated or to target in the younger age group. Now, we've got to remember that this is an audit of what is recorded in the GP primary care record. And this is where, you know, as we all know, I think if we're familiar with audit, there's the espoused theory and the theory in action, what we think is happening, what's really happening. Now, this is a compound indicator, so it's looking at both people who have had their blood pressure recorded and it's below threshold. And so that probably accounts for some of the fall off between the proportion treated to threshold from the elderly to the younger patients in that group. So if we move on. So again, and this is, so we're looking at cholesterol here, and we're looking at people with CVD who are currently on lipid lowering therapy. So this doesn't tell us whether they're treated to target, but it does show us the sort of variation across some of the ethnic groupings here. And what we're seeing is, we all know that, you know, people of Southeast Asian background have poor outcomes for cardiovascular disease compared to most other ethnic groups across the country. And yet here we're seeing they're more likely than other ethnic groups to be prescribed lipid lowering therapy. So this is important in my mind, and equally it shows the marked variation between the sort of Southeast Asian group and the, you know, Black Asian group. All these ethnic groups are from the data recorded on the GP primary care record, which would have been what the patient themselves has identified themselves as. So it's a patient identification in this sense. And one of the important things here is that if we're looking at, you know, why do people from Southeast Asia have such poor outcomes? Well, it isn't necessarily because they're receiving poorer care, certainly in regard to this single element of it. And those sorts of things matter when we make choices as to where we put our interventions and where we put our resources into it. So next slide. And again, this is another side looking at cholesterol, and this again is looking at the number of people with cardiovascular disease treated to target, and it's showing the sort of the difference between male and female. So it's a 10% difference in whether you're treated between the male and female group. And we've done some further research in this, and Liz is presenting a paper at the European Cardiovascular Society later in the year on this. And females are less likely to be offered lipid-lowering therapy. They're less likely to take lipid-lowering therapy. They're less likely to be treated to target around lipid-lowering therapy. And it's actually, they're less likely in the least deprived groupings in this one. So it's one of those things where it's a sort of a slightly anomalous thing to what we might think is going on. And 40% of women die of cardiovascular disease. 4% of women die of breast cancer. And yet breast cancer is something that's in the minds of most women, perhaps more so than cardiovascular disease. So this is an opportunity for us all to address. Next slide. And again, so we've got a couple of slides here, just sort of looking very quickly at learning disability. So again, this was one looking at hypertension. Now, patients with learning disabilities, and these are only people with a learning disability where it's recorded in the GP record as such. And there is some, or historically there's been some work in primary care to try and incentivize to make sure people with learning disabilities do get proper annual health checks to identify and manage the risks of conditions. And that's probably why the percentage of people diagnosed is slightly higher than the rest of the population there. But we still know even with this, their outcomes are poor. So again, it sort of helps us in thinking where might we want to be putting our interventions to improve care moving forward. Next slide. And again, when we're looking at people with severe mental illness here, we're doing slightly less well in this group of patients. But the difference is relatively small, but the difference in outcome, they're 4 times more likely to die prematurely of cardiovascular disease. So there are obviously other elements playing into this as well. So yes, we should be doing more, and we can be doing more in terms of managing and detecting these things in primary care. But there are other elements likely to be in play as well here. As I say, these are only sort of snapshot examples. There's much more detail on the CVDPREVENT website. You can go into that, you can drill down from England level to regional level to ICB level through to practices, and you can work through from there. So if we do move on to the next slide. And again, this is showing some of the mortality data. And on the left-hand side, you can see stroke mortality. On the right-hand side, you're seeing myocardial infarction, so heart disease mortality. And what we see is what strikes me is the marked difference between the Asian groups and the people who identify as black within that. If you're black, you're far more likely to have a stroke than a heart attack. And if you're Asian, you're far more likely to have a heart attack than so. But the risk factors for both of these things are broadly the same. So it's the management of your blood pressures, it's the management of your lipids, it's the management of those conditions. And combined, Black and Asian are the groups who will get the most benefit from this. They're the ones that are having the premature mortality from these conditions, and where we need to probably focus more attention on that. Next slide. And again, I mean, this is something that I think we probably sort of all know, that once we age adjust, the people who are most deprived have a much higher rate of premature cardiovascular disease than the people who are least deprived. The purpose of age adjustment is very important because people who are most deprived die younger, they tend to be younger, and therefore it affects it. So when we looked at atrial fibrillation prevalence, if you look at the numbers, it appears that there are more people with atrial fibrillation in the least deprived group. But that's because the least deprived live longer, and atrial fibrillation prevalence goes up as you get older. But once you age adjust the least deprived and the most deprived, that line flattens out. But here we're clearly seeing that the outcome is far worse in the most deprived. What we don't necessarily see when we go through all the data is that the quality of care that the most deprived patients is necessarily that much worse than the least deprived. There are some differences, but probably not significant enough to reflect the degree of change we're seeing here. So again, the wider determinants of health are very important in this. Next slide. So this is really, I'm just going to do a few sort of sum up. So overall, we've been running this for about 5 years now. All of the indicators seem to be showing sort of slight improvements over time, both in performance, but also in the number of people recorded both as at risk and having events, which is important because the more people we're aware of, the more we're doing to them. We've tried with the parallel tools that practitioners can use in their practice to make it easier, because we didn't just want to have an audit where we were telling people you could have done a better job. We wanted to provide them with some tools that enable them to do that job better. Now, there's a completely parallel audit set of tools that does that. So there's no information that we get. This is all pseudo-anonymized and comes through to us. None of that information goes down to patient level. What we're running is the same rule set, the same business rules in the practices for them to be able to replicate the audit at a practice level. And it's really sort of trying to prevent, early diagnose, better manage, and not overtreat. Now, one of the things I think is a personal success in this is that in secondary prevention of cardiovascular disease, prior to this audit, we had no idea how well we were doing for that in the country. So NICE published CG181 in 2014, and we had no idea how well that was being implemented or whether anything was happening at all. And when we started auditing in the first 2 quarters, so if you remember, it will take 6 months from the data being released to see the impact of any changes to that in practice. The first 2 quarters showed no change whatsoever. The next 8 quarters showed a 13% increase in the number of people treated target for that. So I think that demonstrates the value of audit in focusing people's attention and helping people to sort of monitor and see the impacts of things, and hope that we can succeed in decreasing premature mortality from cardiovascular disease. So I'll pass back there.
Thank you so much, Peter, for an excellent and insightful presentation. We'll now move on to the Q&A section. I'm delighted to see that we're starting to get questions come in. I'll ask Veena and Liz to join Peter in answering the questions, which would be wonderful. And I will read out the questions as they come in. So I think the first question, which is coming from 2 people, really, it's coming from both Eric and Helen, is about very specifically the tools that are available on GP systems. How do you access them? How do you use them, etc., etc.? So maybe that's a question possibly for Liz as much as for Peter.
Yes, thank you. I've put in on the CVDPREVENT website, there's some quality improvement tips and resources available. And I've put the link in from our website that gives a list of some of those tools. So obviously CVDPREVENT data is anonymous, but in order to get the patient information that's required for quality improvement, you have to run the searches on your GP clinical system, and there are various tools that are available, some of them free, some of them part of clinical systems that are already in use in general practice, but that means that the data remains within the practice in terms of the identity of the patients.
Okay, great. Thank you. I'd like to bring Veena into the conversation, if I might, and just to sort of take a step back from CVDPREVENT to having a think about its role in healthcare inequalities more broadly. So, Veena, a question for you is, why is it so important to focus on reducing the healthcare inequality gap in CVD for people of Black and mixed ethnicities?
So I'm an epidemiologist by background, and I've worked for a long time on using NHS data to improve the quality of care and reduce inequalities. And I'd like just to start by saying that CVD Prevent is a goldmine. It is such a valuable tool for both supporting quality improvement and reducing inequalities. And we've seen just a few snippets and examples from what Peter has shown us just now. But I know from working with them and others that there's a lot more detail and similar data behind it. So it really is a very, very valuable tool for addressing inequalities. One of the consistent patterns that emerges in the CVD Prevent data is that Black groups seem to perform less well in terms of being prescribed medication for hypertension or lipid-lowering therapies, and their intermediate outcomes are also worse. In contrast, the Asian groups seem to perform better on those markers. So I think it's really important to try and see what's causing this. And the same is true with the mixed groups as well. Because, again, as Pete showed, the Black groups have much higher mortality from stroke and hypertension. And just to make a quick distinction, if I can, there between the high rates of heart attacks in Asian groups and the high rates of stroke and hypertension in Black groups. This is something that's also reflects to some degree physiological susceptibilities, because we see these patterns not just in the UK, but in the US and elsewhere as well. But to go back to your question, Lacia, it's really, there needs to be much more focused interventions, including at community level, to try and raise the rates of control of blood pressure in Black groups and mixed groups.
Great, thank you so much. A question back for CVD Prevent team, so maybe Liz or Peter, is around the availability of data, and will the availability of CVD Prevent data speed up, given some ICBs are now using the data for quality improvement and or with incentive schemes? So that's a question from Eric.
So I presume by speeding up, you mean become available more frequently? It's currently available on a quarterly basis. And because of the nature of the QI improvement work in general practice and the numbers of patients that are often involved, it's actually quite difficult to show a change in percentage achievement in various indicators more sort of frequently than that. So it's actually the sort of the ideal rate of sharing the data. Obviously, because the data is anonymous, people will be running these searches on their own GP clinical systems, and they will have the sort of most up-to-date information on how they're doing from their GP clinical system in terms of who they've managed to treat to target, etc., from the risk stratification and prioritization searches that they can run on their GP systems. I don't know if Pete wants to add to that.
Well, no, just to add very quickly. So I think the way we think about it is the CVD Prevent will show you where to be looking at within your practice or area compared to other areas. So it will show you your relative performance, where to put your efforts. The reports you then run at a practice level, which identify the individuals to who you need to be looking at, they can run on a daily basis. So on a local level, you can see your improvement day to day, week to week, month to month. Obviously, it will take time for that to filter through, but the important thing is not only to be able to see your improvement, but everybody else is hopefully improving at the same time. So to see how your improvement intervention is working relative to everybody else's intervention improvement, or relative to what might be the status quo, where we would hope there is still improvement, because some of these things are incentivized through policy and outcome frameworks and local initiatives. So CVD Prevent is where you should be looking locally compared to other places. the CVD action, the local tools provide you to who you should be looking at as individuals within that practice. So.
Great, thank you, Peter. A question around risk at different times for females coming in from Sam Morris. So it says, until Q-risk takes into account menopause, early menopause and other hormonal indicators, clinicians won't understand that female patients are at higher risk at different times. Does the panel have any insight into how we can improve this major area for CV health and prevention for women?
So I haven't got the definitive answer, but one of the things that impacts women post-menopausal is an increase in your cholesterol levels. And they tend to be lower in premenopausal women than they are in postmenopausal women. And cholesterol levels in terms of your LDL, non-HDL level is factored into Q-risk. So I would suspect that Q-risk does accounts for that to some extent, because it knows the age of the patient, it knows the fact they're female, and it knows what your current cholesterol levels are. So I think it will account for it slightly. Q-risk, if you remember, is developed by retrospectively going through data in primary care databases and then working out the risk from all that information coming through. So whilst it doesn't record whether somebody's menopausal or not from the recorded record, it could infer it for an average female based on their age. Admittedly, there are there's a big variation in the age of menopause. Some people have premature menopauses, some people have surgical menopauses. So hopefully that answers the question a little bit, but it's not perfect.
Well, it's a tricky question. Thank you so much. I'd like to bring Veena back in, if I might, with a question that I have in advance, which is, what are the implications and wider significance of what CVD-PREVENT data tells us about deprivation and CVD health?
Thank you, Lacey. That's a really key aspect of CVD-PREVENT data. Is deprivation is a critical determinant of CVD outcomes. So 1 in 4 deaths is down nationally is caused by CVD, and the life expectancy differential between the most and the least deprived areas in England is almost 10 years, and almost a quarter of that is accounted for by CVD. So CVD is a massive contributor to inequalities, not just in CVD mortality, but in overall mortality. And it is very closely associated with deprivation. And of course, I mean, one of the points that Peter made earlier, deprivation intersects with some of the other factors. So we talked about the Black groups earlier. So some of the excess that we're seeing in Black groups on some of the poorer outcomes could be down to deprivation as well. And I do think that if we improving life expectancy overall and reducing inequalities really requires a very, very targeted assault on addressing CVD inequalities by deprivation. The north-south gradient is just so striking. And also just to say that these inequalities are widening. They've been widening since 2010. And since the pandemic, premature mortality from CVD actually rose for 3 years. It increased, not just in the UK, that was so in some European countries as well, but we're doing less well. So deprivation is a very key marker and driver of CVD inequalities.
It's very sobering, isn't it? Back to the questions from the panel. There's another specific question, this time around smoking, from Hannah. And Hannah asks, through involvement in the CLEAR programme, we are trying to look locally at smoking history, as well as current smoker status and the link to CVD incidents, forever smokers. Is anyone aware of how the data is collected, recorded, demonstrated within CVD-PREVENT, and whether there are opportunities for greater nuances or detail and targeting when it comes to smoking?
I mean, smoking is clearly a major risk factor for cardiovascular disease and many other illnesses, and any intervention which can drive down rates of smoking, including the use of vapes, is to be encouraged. Smoking wasn't specifically one of the areas that was within the remit of CVD Prevent when it was set up, although, as you rightly say, it is a major impact. I think there are some other data sets that do provide information on smoking. We do try to combine some of the information we're getting through CVD Prevent with other data sets where we can. But I don't think I've got the answers to that question fully at the moment.
Okay, again, so I'm going to come back to a question that I would like to ask while we wait for others in the panel to drop in questions. Please do put in more questions. The questions have dried up. And it's possibly for Liz. I wonder, Liz, if you have any insights for other audits. It's quite an interesting point that CVD Prevent, I know audits all focus on prevention, really, but your utter focus on prevention and your linkage with primary care, I wonder if there's any learning points for other audits in relation to those factors.
Well, I guess there are other sort of national primary care audits that are available. The sort of national diabetes audit is one that I can think of, but for me, the huge advantage of having CVD Prevent data available is that you have actually got a means of monitoring some of that improvement work over a period of time without having to go through the pretty exhausting piece of work to actually carry out the audit yourself. So, for example, I'm a prescribing advisor by background, so a lot of the audit work that I've carried out in general practice has been about auditing the use of certain medications in certain patients. With CVD, we've got a lot of patients that come under that category, and it's really helpful to find that without having to do any complicated audit work, you've actually got the answers to what your sort of current achievement is, so that you can monitor that improvement. So I think for me that's a learning that there is a big advantage in having a system that is sort of automated in that way, and really helps to drive that improvement forward, because as Pete says, it provides that area for focus. But there are lots and lots of areas in general practice where that's the case, and we haven't got these automatic audit data available.
Okay, great, thank you. A question from Marco. He does start by saying he likes the CVD outcome data indicator page. So many thanks for building this in, he says. But moving forward, how likely is it that we can drill down by place, neighbourhood or PCN level, please?
Within the outcomes data?
I think that's what he's saying.
Okay.
The new CVD outcome data indicator page.
So I think that's possible. I mean, I think we just add it to the wish list of things we'd like to be able to do going forward. You can drill down to practice level for the main CVD Prevent data. For some of the indicators where there are relatively small numbers of patients who might be identified, things like genetic diagnosis of familial hypercholesterolemia, that isn't available at practice level just because the numbers would be too low. But the idea is to go to the lowest meaningful level that we can with it. So I think we add that to our sort of future wish list.
Okay, thank you. Liz, back to you. There's quite a lot of interest in quite specifically how people go about using the tools that you have available. And someone is asking, and I don't know if you can quite do this, but can you share a screenshot or a location for the clinical system searches, please? They're saying that we could only see the template names in the link that you send. Is there any more information you can give to specifically guide people to where they need to go?
Yes, it's very difficult to show that at a session like today, but basically if you go to that link that I sent and click on the links on the website, it will actually take you to where those particular sort of software systems are. There's a whole host of them. So some of them are to do with the GP clinical system that you have. Some of them you have to actually download. So for example, UCL Partners have searches, clinical searches that help risk stratify and prioritize patients. And they're available for both EMIS and System 1. They're free of charge. There are other similar organisations that have produced those sorts of search tools. We don't have an extensive exhaustive list of those, but and people may know of more. They're not, we don't work with them, but obviously if you use the CVD Prevent data to identify what needs to be done, you can then run some of those searches on your own clinical system, and some of them are built into your own clinical system. Some of the Ardens packages are the same searches, for example, that are on the UCL Partners system. So if that makes sense to people, and you can actually then focus. For example, you can look at all those patients who are not just haven't got their hypertension controlled to target, but you can actually risk stratify them and find the ones that have really high blood pressures, and then move on as you sort of go down at the level of risk of those patients. So it just makes the looking at the patients that you need to review in a sort of prioritized way much more manageable.
Okay, that's great. There's a sort of follow-on question around having help to find and use the audits on EMIS. I don't know if you have any insights on that, and or is there an email address or somewhere, if people go into your website, have a good dig around, look at what's available there, look at the tools, but if they get stuck, is there a place that they can come with these sorts of practical questions?
Yes, I mean, people can get in touch with me if I don't know the answer. I can usually help direct to people. So I'll put my email address in the chat, and feel free to get in touch later if it's not really making too much sense at the moment.
I think the other thing I would say though is it's familiarity. So once you work out how to work out one indicator, so whether the blood pressure has been treated to target, look at the national level, look at the regional level, look at your ICB level, go down to the individual practices, look at the variation. That process is exactly the same for any other indicator. Equally at the practice level, when they're running a report, whether it's the CVD action reports, the UCLP, the Ardens reports, all these reports work in exactly the same way as any other report that might be running in the practice. And there will be somebody in that practice who knows how to run these reports and knows how to pull the patients from them. So once you know how to do it, you can do it for the next bit. So it's a sort of very repetitive process. And the whole idea is to make this simpler for clinicians to be able to identify the people who would most benefit from the interventions. And ideally, building some prompts into the clinical systems themselves so that we have what I call clinical sat-nav. It doesn't tell me how to manage my patient, but it does remind me what I might have missed doing had I not had the opportunity. As in, I haven't done the blood pressure for the last 5 years, or I've never checked their cholesterol, or things like that. It may be appropriate to that consultation, it may not be, but at least it gives me that sort of bit of guidance.
Okay, that's great. I'm going to show that I am, in fact, able to multitask by leaping across to the chat and choosing a question that is from Angela. Given the interconnected nature of cardio-renal and metabolic diseases, how can CVD Prevent evolve or collaborate to tackle the NHS's focus on prevention and integrated care, specifically earlier CKD, diabetes identification, medication initiation, and better outcomes to reduce CVD episodes. I'm not sure if that's one for CVD Prevent or whether that's a broader question maybe for Veena. Would someone like to jump in on?
So if I pick up, so Veena, you were about to come in. Go ahead.
No, I was just going to say, I think that's one for you guys.
Okay, fair enough. Thank you. So, so what we don't do at the moment is we don't know exactly how many people have or haven't had a blood pressure record, or haven't had their cholesterol record, or haven't had their CKD recorded. What we do know, though, is the people who've had their 2 eGFRs below 60, so have a diagnosis of CKD3, even if it's not been recorded. So we can identify people from their blood results who should have a diagnosis recorded against it. Once we have a diagnosis, we then can look at how well we're managing it, particularly with CKD. It's how well we're managing the blood pressure, how many of those people are on lipid-lowering therapy. And we can do that again for diabetes, and we can do that for some of the other conditions. What we're trying to do, and what we do when you run the report at a practice level, when you run the report at the practice level, you're not asking it to just tell you, you might be running the report on people who've got high blood pressure not treated to target. But when you find that individual, you don't want to then just think about, do I do their blood pressure? You want the report on the individual to come up with, oh, by the way, they've also got diabetes and kidney disease, therefore their blood pressure target is different, and we haven't done this. So at the practice level, you wouldn't be sending out one blood form just to check one indicator. You'd be doing all the relevant tests, you getting them in, because we are treating people. We don't treat conditions. As clinicians, I'm a GP, I treat people. They happen to have a number of different things, and the way we've described those according to what we can measure or the organ it affects most is rather arbitrary. Cardiometabolic syndrome affects multiple organs in multiple different ways, and we're looking after the patients, not the bits. So at the practice level, you would look at it holistically.
That's great, thank you. We're coming towards the end of our Q&A session, but I would like to give Veena one final opportunity. If you'd like to say anything more broadly around healthcare inequalities and how it's important, how clinical audit might have a role in supporting or addressing healthcare inequalities.
Yes, I would do. I've seen some of the other clinical audits, but I haven't seen many that put out routinely and regularly, right down, at such detailed levels, in terms of different indicators, inequalities by such a wide range of dimensions. As Pete said, they haven't started looking at intersectionalities yet, but, that's for down the line. But, the inequalities that you can see by age, sex, ethnicity, deprivation, mental illness, and so on, this is such a valuable tool for informing improvement and inequality reduction initiatives. And I think it's a very, very powerful tool if it can be fully used and exploited, and not just by the clinical fraternity. This data needs to be acted on by ICPs and local government as well, public health agencies and so on. So it is a very valuable tool. We will not be able to reduce inequalities unless we use data more intelligently and more widely than we do currently. And this is a very good example of where to start.
That's wonderful. So thank you so much to our panel. That does bring our Q&A to a conclusion. Apologies if we haven't had a chance to get to your question, but you can either email HQIP, communications@hquip.org.uk, or do have a follow-up with CVD Prevent if you have an outstanding burning question. So, of course, I'd like to thank our panel, Peter Green, Liz Corteville, and Veena Raleigh. It's been wonderful to hear from you. It's been so insightful. I'd also like to thank everyone for taking part in today's event and the wider Clinical Audit Awareness Week campaign and making it the success it is. Before I let you go, I've just got a moment just to remind you of a couple of things. Please look at our website, hquip.org.uk. There's a new video that's gone up today, a video and podcast by NHS England's Dr. Aoife Malloy and HQIP's Danny Keenan, and they are talking about healthcare inequalities and the role of clinical audit in addressing it. There's a new blog article from the National Prostate Cancer Audit, and they explain how their data is helping to identify multiple inequalities in diagnosis and treatment. And there's a new case study among other things as well. So the case study is around embedding health inequality assessment within routine clinical audit. Finally, don't miss our remaining live events. There's 2 online lunch and learn events at 12:30. Thursday on influencing change and Friday on efficiencies in healthcare. And don't forget, during those 2 events, we'll be announcing the Clinical Audit Heroes Award winners for those categories. We've got a very, very exciting event coming up tomorrow at 2:15 p.m. Data-driven improvements in maternity care, a regional medical director's perspective, and that's featuring NHS England's Dr. Edward Morris. And then finally on Friday, there's an event at which we will hear the announcements of and see presentations from 2 award categories using national clinical audit, specifically the NCAPOT programme, and communicating for impact. So please come along to those events. You need to register in advance, but just hop across to the HQIP website, hqip.org.uk, and you'll find a page there that has all the information, including links to register. Finally, we'd love to receive your feedback. So please complete this short form. You can scan the link on the screen. We'll leave it up for a few minutes at the end of this meeting. So all that reminds me to say is to sort of say a final thank you from HQIP. An absolutely enormous thank you to Peter, Liz and Veena. An equally enormous thank you to all of you, and we hope to see you again tomorrow.